Hello, everybody. We will get started in just a moment once everyone has had a chance to join. Welcome to today's webinar.
Maybe we can get started, Ian.
Absolutely. Hello, everyone, and welcome to today's TTAC virtual conference. Pregnancy is a time of hope and fear, exploring the biological, emotional, and social dimensions of the perinatal period with our host, Dr. Alicia Lieberman. My name is Ian Elliott. I'm the TTAC program coordinator at the McSilver Institute, one of the TTAC partners, and I'm so happy to be joined by our presenter, our panelists, and all of you today. As we've done in the past, the webinar will be recorded, and both the slides and recording will be posted online after the event. We'll be taking questions throughout the webinar. We ask that you chat in your questions using the chat box functionality. We will collect them and answer them at designated periods throughout today's event. For those LMSWs and LMHCs interested in obtaining CEUs, you'll be eligible to receive 3 CEUs for attending today's webinar. Please be posted. Information about that will be sent following the event in a post-event email. Finally, towards the end of the webinar, we'll be sending out the feedback survey using the chat box functionality. We ask that you click the link that is shared in the chat box and complete the feedback survey. We appreciate you filling this out as it allows us to understand your experience and enhance our future TTAC offerings. With that, I want to thank you all for joining us and hand things over to our partner, Evelyn Blank, Executive Director at New York Center for Child Development and Director of TTAC, who will walk us through a brief introduction before our presenter begins. Thank you.
Thank you so much, Ian. And if we could just go to the next slide. I just briefly wanted to let those who don't know who TTAC are, who we are. TTAC is funded through the New York City Department of Health and Mental Hygiene. It's a partnership between the New York Center for Child Development and the McSilver Institute on Poverty Policy and Research. New York Center for Child Development has been a major provider of early childhood mental health services in New York, with expertise in informing policy and supporting the field of early childhood mental health through training and direct practice. NYU McSilver Institute for Poverty Policy and Research houses the Community Managed Care Technical Assistance Center and the Managed Care and the Community Technical Assistance Center, which offer clinic, business, and system transformation support statewide to all behavioral health providers. TTAC is tasked with building the capacity and competencies of mental health and early childhood professionals through ongoing training and technical assistance. You'll see up on your screen right now a screenshot of our website. For those who are not familiar with it, I would really encourage you to go there, where we archive all of our previous presentations, both the recording of the presentation, as well as the PowerPoints, as well as other resources. We also just recently released 2 learning modules, which are really introductions to the field of infant and early childhood mental health. I know a lot of professionals are asking what are some foundational trainings that they can offer to new staff, and just to let you know that they are there. So I'm really excited about today's topic, which I think is so timely and so important. And today's presentation will focus on pregnancy as a time of hope and fear, exploring the biological, emotional, and social dimensions of the perinatal period. This will be followed by a panel of distinguished experts from cross systems working with those in the perinatal period, describing some innovative programming and supports that are being offered. And again, our intent today is to move from theory to practice and to really highlight some of the innovative work that's being done. And although I think we've made some major strides, I think we've got a long way to go. And it is really important today to frame our discussion in the context of the current stark systemic and racial inequalities impacting on maternal mental health and mortality. I know Dr. Lieberman will touch on this today, but we really also need to understand the impact of social determinants of health on people's access to services and their ability to really get the support that is needed. I also wanted to highlight a brief report, that was done by the New York State Maternal Mortality Review Board in 2018. They reviewed all of the pregnancy-related deaths in New York State, and I think the findings were quite astounding. They found that mental health conditions represented the 3rd leading cause of pregnancy-related deaths, and they also determined that these deaths were potentially preventable. So with that as a backdrop, it's my extreme honor to introduce our keynote today, Dr. Alicia Lieberman. Dr. Lieberman has been one of the true pioneers and leaders in the field of infant and early childhood mental health. I'm going to shorten her bio just because we really want to get into the keynote here, but she holds the Irving B. Harris Endowed Chair in Infant Mental Health. She's professor and vice chair for faculty development at University of California, San Francisco Department of Psychiatry, and director of the Child Trauma Research Program at Zuckerberg San Francisco General Hospital. She directs the Early Trauma Treatment Network, a center of SAMHSA National Child Traumatic Stress Network. She is the senior developer of child-parent psychotherapy, which, for those who don't know, is an evidence-based treatment for traumatized children aged birth to 5, broadly used nationally and internationally as an evidence-based treatment for traumatized young children and their parents or caregivers. Her research involves treatment outcome studies with traumatized young children from low-income and underrepresented minority groups. She is the author of The Emotional Life of the Toddler, described as groundbreaking, and now in its 2nd edition to mark its 25th year in continuous print. She is also the author of numerous professional books and articles on early childhood mental health. Her work has been translated to several languages, including Arabic and Hebrew, and is used to increase understanding and foster dialogue between Israeli and Palestinians working with bereaved and traumatized young children and their families. Her most recent publication, so relevant to today's presentation, is Make Room for Baby, Perinatal Psychotherapy to Repair Trauma and Promote Attachment. She was born in Paraguay. She received her professional training in Israel and the United States. Her cross-cultural experience as a Jewish Latino informs her commitment to increasing access and raising the standard of care for low-income and minority children and families. And I could keep going, but she is on national organizational boards, and in 2019 was appointed to the California Early Childhood Policy Council, and she has been the recipient of countless awards. So it is now my privilege to turn it over to Dr. Lieberman.
Evelyn, thank you so much. It's a great privilege to be here, working with you, partnering with you. It's one of my deepest pleasures professionally. So thank you so much for this opportunity. And thank you all for being here. Thank you for the panelists. I'm so looking forward to listening to your presentations as well. The reason I chose pregnancy as a time of fear and hope and fear has already been alluded to by Evelyn when she talked about maternal mortality in the study that was just released in New York. In terms of the hope, I think nothing quite compares to the power of creating new life and the sense of awe, gratitude, joy, amazement that can come from creating new life, particularly when this is something that has been done with mindfulness, conscientiousness, readiness. And at the same time, it's also a time of uncertainty and fear because we are, when we're pregnant, at the threshold between life and death. In spite of amazing technological advances, childbirth is still a dangerous time. And it is often forgotten that more women died in childbirth during World War I than soldiers in the battlefield. And I think that that sense of not keeping in mind what happens to women during childbirth continues to this day because the United States has the highest mortality rate among developed countries, is the only developed country where mortality rate among women has continued to increase, has doubled in the last 30 years, and yet it is not considered a national scandal, which is what should be. And so I hope that today we are together in increasing our consciousness about the importance of creating a village in support of pregnant women, pregnant fathers, and their babies. And I want to say here that I will be talking about pregnant women and fathers in the full understanding that it is not a completely inclusive language, that there are trans women who give birth and that there is gender fluidity. And the reason I am using still gender language is because the literature is on gender language. Our work has been on women that identify as women and men that identify as men. And so it is what I know. I think that it is important to study what happens with pregnancy in the trans population, and it is an important area for further clinical work and practice, as well as research. Pregnancy is a time of transformation. It transforms bodies, minds, identities. As an example, or as a manifestation of how transformative this time is, I want to refer to the fact that this is a time where women have lots of dreams. And these dreams often suffuse their waking up and puzzle them during the day. And we know that when dreams are very active is because our unconscious mind is very active. And just to give you a flavor of some of the common themes in dreams during pregnancy, often the dream is that we're giving birth to a pet, a doggy, a cat. Some women have reported that they started out by giving birth to a duck, and then to a cat, and then to a dog, and then to a baby. And it's as if the psyche is preparing itself for what's this going to be like? How much responsibility will I have? Others, giving birth to an alien is a very common dream, which might show this is a very strange new experience. I don't know what will happen. There are dreams of water. Water symbolizes life. The fetus is swimming in amniotic fluid. Some dreams are about drowning, about waves crashing on the shore, which some people interpret as perhaps the anticipation of what will the birth be like. Partners make appearances in dreams, partners cheating, which shows about the uncertainty of what will happen. Am I still attractive? Will I still be wanted? Previous lovers reappearing, perhaps thinking, oh, I look forward to a carefree life the way I used to be when I was a teenager. Forgetting where we put the baby, which is, will I be able to cope with this? And so again, this is just a flavor of the profound work that happens internally in the process of being pregnant. And we need to think of this from a perspective of developmental psychopathology, which is a very comprehensive field that looks at normative development, deviations in normative development, age trends in development from the perspective of what are the risk factors and what are the protective factors in everything that we go through. And in pregnancy, there are changes at the physiological level, the psychological transformations, changes in the intimate relationships with a partner, changes in the roles and how we're seen in the extended family, changes in social roles. And these individual transformations need to be looked at in the context of the sociological realities that Evelyn referred to. And again, I'll repeat, maternal mortality in the US doubled in the last 30 years, in spite of amazing technological advancements, which often do not trickle down to populations without access to resources. COVID has been shown to compound the risks of birth at our own hospital, the San Francisco General Hospital. We have found a sharp increase in childbirth emergencies during COVID, and the increases have been disproportionate in underrepresented minorities, particularly in the Black community, where Black women are 3 to 4 times more likely to die in childbirth than white women. And the social context is insufficient social and governmental support for new mothers and fathers. We really have a very fragmented and tattered support system. And of course, we cannot omit mention of the destructive impact of legal attacks on reproductive freedom and access to reproductive choices that deprive women of choice and threaten their life and health. The National Public Radio had an article yesterday, had a program yesterday interviewing OBGYN providers who talked in very vivid terms about actual situations of risk to health and life as a result of these legal attacks. At the physiological level, we want to go over quickly over the different levels of transformation. At the physiological level, there are anatomical, physiological changes that are made to nurture and accommodate the developing fetus, and every organ system of the body is involved: the heart, the lungs, the kidneys, blood supply, the amount of blood in the body, brain, every organ of the body, including changes in sensory experience, smell, taste, even blurred vision sometimes. There are about 10 hormones that are related to pregnancy that are actively released during pregnancy. Progesterone, estrogen, oxytocin are just the best well-known of them. And so mood swings are very prevalent at this age, and weight gain is an important factor that increases the body workload from any activity. So at the physical level, everything feels different. And for fathers to be, it is remarkable that there are physiological changes that often mimic those in their pregnant partners. So that, for example, there are decreases in testosterone and increases in oxytocin, as if the men are getting ready to nurture rather than to mate. Often there are weight gains, BMI increases, there are mood changes and symptoms that mimic pregnancy, like nausea, decreased sleep, food cravings, and digestive changes. And these changes in male partners are during pregnancy and into the first year of the baby's life. So they are lasting. And very often we forget to include what is the experience of the father to be in this process. And I hope that today we can be very inclusive in thinking of the pregnant woman in the context of the partner and the family. Now, at the psychological level, pregnant women report increases in vulnerability, crying at the drop of a hat sometimes, feeling easily hurt in their emotions, fear of losing control over their life. There's realistic anticipatory anxiety about childbirth. Will I be well? Will I survive? What will happen to me? There's also a reemergence of childhood conflicts that have been laying low as the goals of adulthood are being pursued, but that come back in the form, for example, of fear of death, fear of not being loved, fear of being damaged, fear of not measuring up to the expectations of this role. And there is a reworking of one's relationship with one's own mother and father, a going back to memories from childhood, hurts from childhood that are coming back, often in dreams also. And all of this is part of a process of accepting and incorporating the fetus in one's sense of one's body and oneself. For fathers to be, there is evidence now that there is an innate sense of nurturance, of fatherliness, that is, as I said when I talked about the decreases in testosterone and increases in oxytocin, is really at the biological level that is mobilized. And for men in particular, there is a greater influence of social and cultural expectations. what is a father expected to be? And that changes a lot in different cultures and in different times within a culture. So that, let's say, in the 1950s, there was less expectation that fathers would be present during childbirth, that they would be actively involved in taking care of the baby. Those gender role expectations have changed. And with those social expectations, also a different sense of self in the fathers to be in relation to becoming a father, so that the fluidity in gender roles and individual choice blur the boundaries between culture and biology. And I want to speak here about the frequent exclusion of fathers from systems of care. We talk, for example, about maternal and child health. We don't talk about family health. We don't talk about maternal, paternal, and child health. And I think that that kind of restricted language often gives the unanticipated message of being superfluous, being unwanted. Barry Brazelton, the wonderful pediatrician, said that when he used to get phone calls from pregnant women asking for an appointment for after the baby was born, he would say, "And when can you and your husband come?" That time it was primarily husbands. Now we would say partners, most likely. And the women were often surprised by, why would my husband need to come? And he would say, because this is a family experience. I think we should, he was a pioneer, and I think that we're still trying to catch up to his example of involving fathers. And there are, among the transitions, big changes in interpersonal relationships, changes in the relationship with the partner. And the factors here, protective factors, risk factors, have to do with how stable, safe, and secure is the relationship with the intimate partner. Was the pregnancy planned, and was the pregnancy wanted? 45% of pregnancies in the United States each year are unplanned. But that doesn't mean that they are unwanted. 18% of these 45% of pregnancies are labeled as unwanted when people are asked. And of those 45%, 27% say, "I would have wanted it later, but this is not quite the right time." And the question of, is the pregnancy wanted by both partners? Or if it was unplanned, is it accepted by both partners? There's a lot of research showing that when the two partners agree on whether they want or not want the pregnancy, there is a much better chance of whatever happens happening in a smoother way and the outcome of the pregnancy being better. One of my colleagues, Angela Narayan, when she was a postdoctoral student, found in a sample of pregnant women who were asked, how do you feel about the pregnancy? How does your partner feel about the pregnancy? She found that when the woman perceived the partner as not wanting the pregnancy, they were more likely to be depressed than if they themselves did not want the pregnancy. And I think that it shows you how important relationships are during pregnancy, particularly relationship with the intimate partner. And of course, another component is there agreement between the partners about how they will navigate economic, social, sexual expectations, the changes that occur at every level, from the most intimate sexual domain to the question of the new expenses, the new housing demands, for example? How will they face the world as parents? And will there be agreement about how the baby will be raised? If it's two different cultures, two different religions, who will take care of the baby? Will there be equality between the mother and the father, or will one partner have primary responsibility? All these are very exciting but potentially thorny issues that make their appearance in a new way. And of course, couples and individuals live in the context of their families, of their societies. The whole question of how does the family respond to the pregnancy? Are they happy? Do they feel that it is foolhardy to get pregnant at this time? Are they going to be welcoming or judging? Are they going to be supportive? Are they going to be available physically or emotionally? Do they have the material resources and emotional resources? And poverty, lack of resources, is an enormous risk factor during pregnancy and in the aftermath. We talk here about the permeability of the different levels of experience, and this has to do primarily with the mother. Evelyn referred to my program and I developing a form of treatment called child-parent psychotherapy. And this triangle, the external part of the triangle, is what we call a clinical formulation triangle, where we think together with the parent and the child about what happened to you, what's your life like, what are the good things that happened to you, what are the traumatic, the adversities that happened to you. And then how do they link to how you are feeling now, the thoughts, the experiences, the feelings, the behavior, and how can we help? How can we make use together of the things that go well in your life, that give you a sense of well-being, to make life better for you? During pregnancy, we have evolved this triangle so that we are thinking of three embedded triangles. The outside is the mother's experience of herself as an individual. The middle triangle is pregnancy. How does she feel about her body and about the pregnancy? And the innermost triangle is how does she feel about the baby? And this is something that really helps us to think when we are meeting with a mother, when we're meeting with a father to be, to think of what is the relationship between the external circumstances, the internal experience, and how we can position ourselves to make use of the strengths of the protective factors to bring together forward change. I'll give you one example of how these permeable membranes between the individual, the pregnancy, and the attitudes towards the baby can play out. This is a pregnant woman in particular who was left by her partner soon after letting him know that she was pregnant. And she thought that this was a firm relationship. It was an unplanned, one of the 45% of unplanned pregnancies, but there were plans of marriage, there were plans of being together, there were plans of moving into a new apartment together, and he disappeared. Soon after, she told him that she was pregnant, and she found herself blaming herself for getting pregnant accidentally and for making him go away, in her words. And the permeability of that external of that experience of herself as an individual got manifested into her pregnancy. She had lots of symptoms: dizziness, heartburn, very swollen feet, fatigue, nausea, sleeplessness, lack of appetite, throwing up. And when she was asked to think about the baby, she said, he starts moving just when I am finally falling asleep. It's like he can't stand to have me rest. He pokes at me really hard and it really hurts. Was already seeing the baby as an aggressor. And it was as if she was displacing on the baby her anger at her partner. And as we asked about her childhood, what her life was like, it emerged that her father had left and that she blamed herself for her father leaving. She blamed herself for her mother's depression following. She said she wasn't a good child. And that sense of not being good enough emerged in the new circumstances of her life, and pregnancy served as the catalyst with the unfortunate circumstance of being left. Another woman, on the other hand, was describing in similar circumstances, single, a pregnant woman with a history of trauma as well, said of her pregnancy, "This is a new beginning for me. I am going to be my own boss. I am not going to depend on anybody." And she said, as she kept growing, she said, "I feel like a sailboat, and I feel like my stomach is a sail that is filled with wind and is pushing me forward." So two women in difficult circumstances responding quite differently to the circumstances of their pregnancy and to their body and their perception of the baby. Now, we know that pregnancy, it's good that it lasts 9 months because it gives us time for creating a coherent identity as a parent and as a co-parent. And the growing love for the unborn baby supports the creation of a new identity as a parent, as a salient new aspect. And in that process, there's a lot of energy that is devoted to reconciling the demands of multiple roles, being an intimate partner, being a breadwinner, being a mother to or a father to older children, working, being a friend, etc., etc. And each pregnancy is different because the circumstances for each pregnancy is different. Every baby comes in a slightly different home environment, even if it is 2 or 3 years between the pregnancies, the circumstances are different because every baby creates a new family circumstance. But there are overriding themes which have to do with, can I do it all? Can I remain true to myself while being a good parent? Can I be a better mother than my mother, or a better father than my father? Or they were such good mothers and fathers, can I live up to who they were? And one of the big challenges is accepting ambivalence. There is so much pressure in the society, in spite of the lack of support that we give to parents to be and to new parents. So much pressure to idealize being a parent, so much judgment when one gets mad at one's children, impatient, uncertain, ambivalent. it's as if all those departures from an idealized version of what it's like to be a partner become a source of social judgment and then self-judgment. And I think that we need to think with a great deal of compassion about the women and the men and the individuals who get pregnant and who are grappling with their ambivalence. And we need to strive to remember that ambivalence is a normal adult frame of mind, that conflict is a recurrent adult experience, and that the question is not whether there is conflict or whether there is ambivalence, but how we cope with it, how we resolve it, how we manage it. And in this process, the question of what is the support that the parents have? Are the intimate partners present and available, antagonistic, violent, competitive, blaming, or loving, reassuring, supportive, or the whole range? Because we know that people often have the entire range of emotions. And the question is, which ones predominate, the positive emotions or the negative emotions? Oops. Okay. In the process of creating a coherent identity as a parent and as a co-parent, there are actual behaviors that we can look for that are manifestations of this embracing of the parenting role. And these include a heightened keeping the baby in mind. My dear friend and colleague Arietta Slade developed treatment called Minding the Baby, which I think is just a brilliant title for keeping the baby in mind, remembering the baby in every aspect of one's life. And so that one incorporates planning for the baby in what does one eat? Is one eating well? Is one avoiding harmful substances, not smoking, not drinking too much, for example? Affectionate behaviors like caressing the belly, talking to the fetus, and nesting behaviors, preparing the home by making a physical space for the baby, buying clothes and equipment. One of the very first pregnant women that I provided treatment for many years ago came for treatment because she recognized her ambivalence in the fact that she could not buy anything for the baby, diapers, bottles, prepare a room in her apartment for the baby, even though this had been a planned and wanted pregnancy by both mother and father. And she realized that this really said something about her readiness. This was in the 8th month of pregnancy, so it's not as if she had months and months to prepare. So the way that pregnant partners behave during the pregnancy in terms of preparing for the baby is a very important indicator of how ready they are. And this takes us to specifically something that I want to focus on, which is maternal mental health, because mental health difficulties are prevalent in pregnancy. 1 out of 5 American women experience depression, anxiety, post-traumatic stress, psychosis in the pregnancy and the peripartum period, and they are among the most frequent complications of pregnancy and childbirth. And I think that we have to remember how little support they have governmentally in terms of social structures, how alone pregnant women and their partners are. And substance use and suicide are very high among the leading causes of death postpartum. And 4/5, 80% of these maternal deaths are considered to be preventable. Again, the racial inequities. A college-educated Black woman is 60 times more likely to die in the perinatal period than a white woman with less than a high school education. One of the really shocking findings is that education and income do not ameliorate the mortality risk of Black women during childbirth and the perinatal period. And so the pervasive racism is something that really needs to be deconstructed, including implicit bias. Black babies were 3 times more likely to die when delivered by a white doctor than by a Black doctor in a study of 1.8 million hospital births in Florida between 1992 and 2015. And for white babies, the race of the doctor who delivered them did not make a difference whether the doctor was Black or white. So these are very stark, shocking, scandalous statistics that we need to really, really live with and act against. In one study that we did in our own hospital, the Zuckerberg San Francisco General Hospital, which is the trauma center for Northern California, we interviewed 101 pregnant women receiving prenatal care. 62% of them were below the poverty line, and there were very representative, 37% Latinas, 22% Black, 20% white, 21% mixed, and 55% of them reported that they had 4 or more ACEs, adverse childhood experiences, 4 or more. These are women in their 20s and 30s. And we know that 4 or more ACEs are associated with a decrease that can be as much as 20 years in longevity. It really affects the lifespan as well as the leading causes of death. 32% reported 6 or more ACEs. 62% had unplanned pregnancies, and 44% had an unwanted pregnancy during their lifetime. Again, the intimate partner violence was huge here, 56% before the pregnancy, 14% during the pregnancy. By themselves, 20% of them said that they themselves were aggressive towards their partners, and there was very high levels of clinical depression, PTSD, and comorbidity, and yet 67% of them in a hospital that is the trauma center for Northern California, 67% of them said that in spite of all this very, very worrisome profile, they did not receive mental health services. So, and San Francisco General is a wonderful, very caring hospital. And it just shows how all of us are so vulnerable to the systemic failures in the systems of care. And this has an impact on babies. There is what's called a fetal programming. And we are going to hear from our panelists about this because they are really in the know about how that fetal programming happens. But we do know that prenatal maternal stress is linked to alterations in fetal development, in the transmission between the placenta and the fetus of stress physiology, in the brain structure of the newborn baby. There's a marker for self-regulation that is called respiratory sinus arrhythmia that gets distorted in babies when the mother is under extreme stress, and this RSA has been associated with long-term risk for psychiatric conditions. And all of this is exacerbated by risk factors like unwanted pregnancy and exposure to intimate partner violence. We also know that in addition to the actual biological impact on the fetus, there is an intergenerational transmission of trauma, so that women that have histories of child maltreatment and IPV are more likely to experience postpartum depression, that women with histories of childhood trauma showed increased morbidity, the co-occurrence of postpartum depression and PTSD, that these women are more likely to engage in child abuse, and that their babies are more likely to have poor perinatal outcomes. And in particular, I want to focus on the impact of IPV because it is so pervasive. As you saw, 56% of these 100 women that we were just interviewing by putting flyers next to the elevators and in the bathrooms in the women's clinic saying, "Are you pregnant? Do you want to come and talk to us? We'll give you $70 for telling us about your pregnancy." It was a non-clinical sample, and 56% had exposure to domestic violence. The medical complications of IPV are enormous. UTI, preeclampsia, anemia, kidney infections, placental abruption, hemorrhages. Brain injury. There is emerging evidence, very convincing evidence, that blows to the head, being choked, can create minimal brain damage that through, for example, deprivation from oxygen, and this can often be manifested in ways that we do not relate so much to how were you abused, what happened to you, so that the woman might feel disorganized, not thinking straight, getting easily dysregulated, and we give it a psychiatric diagnosis very often without realizing that there is a very clear biological substrate for it. Women who are victims of IPV also often delay prenatal care. They have more unwanted pregnancies. Physical, domestic violence, and sexual abuse are often co-occurrent, and they often resort to substance use as a way of coping with depression, hopelessness, and of course, femicide is a real risk among women. And for the baby, the outcome of IPV for the fetus is very serious. Low birth weight, preterm birth, increased NICUs, increased hospitalizations, and after birth, more health problems, including more vulnerability to infections. And there is a 40 to 80% overlap between IPV in the home and child abuse across different studies. So it's very interesting that for many years at the Child Protective Services in San Francisco, they used to say domestic violence is an adult problem, is not a childhood problem. And more we know that domestic violence affects children just as much or worse than it affects adults. So how do we break this intergenerational transmission of pain? it is very clear that no discipline can do it alone. And we must create interdisciplinary system collaborations, family planning, so that we can have access to birth control options and preferences, awareness of emotional issues in the OBGYN for prenatal care, labor and delivery, postpartum uh, uh, unit, primary care in the NICU, pediatrics, family medicine, access to family resource programs that provide concrete assistance, and mental health services. In our own program, it is perinatal child parent psychotherapy, but there are wonderful interventions all over with pregnancy. Co-PCPP is co-parenting. Child parent psychotherapy is a form of psychotherapy where we involve the father, even in situations of great conflict, and where we assess for safety as part and parcel of the intervention. And of course, adult psychiatry needs to be involved as well when it's a relevant service. I want to talk briefly here about what we call the perinatal child parent psychotherapy model, which we developed at my program with the leadership of Dr. Gloria Castro. She has been now for more than 15 years on site at the women's clinic where pregnant women receive prenatal care, and does weekly check-in with the social workers at the women's clinic to talk about the different patients that they see and what their needs are. And she also has an on-site presence at the OB psych clinic of the hospital, and is also on site in the labor and delivery and on call for labor and delivery situations in the postpartum unit, in the NICU, and with pediatrics. And her presence serves also as a referral mechanism when on-site consultation and intervention is not enough, and more intensive intervention is clinically indicated. And Gloria's wisdom about the interface between primary care during pregnancy and after pregnancy, the perinatal period, and pediatrics, the interface between primary care and mental health really is the sweet spot for creating healthy impetus for healthy parents and healthy babies and healthy parent-baby relationships. And in that sense, we think of perinatal intervention, perinatal child parent psychotherapy, as an integration of prevention and treatment. Again, this is one example, and I want to highlight that not all pregnant women, not all fathers-to-be, not all couples need intensive intervention. I am talking about perinatal child parent psychotherapy as an example of when intensive intervention is needed. But we need a continuum of opportunities, from brief intervention, mindfulness-oriented interventions, which can be very, very, very effective, to more middle of the road interventions that involve connections with concrete sources of help, to when there are serious psychiatric risk factors, more intensive intervention. And this is what I'm going to be talking briefly here of perinatal child parent psychotherapy as a two-generation, multi-theoretical, integrative approach where we look at what are the developmental needs of these parents, where are they in their life cycle, what is their cultural background, what are their values, their beliefs, their practices from a cultural perspective. And then we use a combination of strategies from understanding how the past continues to affect the present to what are the attachment patterns that they've learned and are now getting ready to perpetuate with their babies, to how has trauma affected their view of themselves and of the world, to CBT, cognitive behavioral strategies for self-care. And we use a lot of mindfulness, body-based practices for relaxation, for becoming more self-aware. And the therapeutic focus is what are the perceptions, the negative attributions, the negative perceptions, the pathogenic beliefs that they have about themselves and about the baby. Like the mom that I told you about before, who thought that the fetus was poking her on purpose, was moving on purpose, just as she was going to relax. We have so many examples of women attributing to the fetus malevolent intent, when in fact, those attributions have been rooted in the things that happened to them, in how they were treated by their own parents, by their own loved ones when they were growing up, and by the circumstances of their lives. And helping them understand how the past continues to affect the present is often a source of great liberation and an intervention that opens the door for more hope rather than more fear. And it's always relationship-based, attention to the impact, as I said, of past adversity and relational experiences, and trying to heal current relationships. And I think that it's important to think where in the pregnancy is a mom, is a dad. Is it in the first trimester when they're just coping with the impact of realizing that they are pregnant? Is it in the third trimester when they are preparing for childbirth and the fear associated with childbirth very often, particularly in women who have had sexual abuse either in their childhood or in their adulthood, who have domestic violence now, so that the stresses of childbirth are reminders of the painful things that happen to their body. And then, of course, the perinatal period and the second trimester is often such an ideal time for referrals because it gives time to reflect, to prepare. It's kind of an in-between period where they've already become accepting of the fact that they are pregnant, made the decision to continue the pregnancy, and are not yet bombarded by the anticipation of childbirth. And I don't know why I went back. Oh, this is the book. I'm sorry, for some reason it is skipping. Just this is the book that Evelyn referred to, Making Room for the Baby. Just please excuse me. I just want to make sure that. Okay. And in the treatment, we can go back and forth between the past and the present, between childhood loneliness, fear, and rage. One woman, for example, said that the woman that I told you about, who could not prepare the room, could not buy diapers, could not buy a bottle, she finally said, I always had this fear that I would squish a little puppy or a kitten or a baby. I'm terrified that I'll do that with my baby. And I managed to say to her, and you really want to protect the baby? And she said, you mean I'm capable of protection? I'm capable of giving love? I never knew that. She had such a damaged view of herself from the way she had been treated, that being told that her self-perception was based on how she had been told she was, but not really on who she was, that she was capable of love, gave her new hope. And a very important part of the treatment is helping the woman and the family prepare for the birth. And Gloria Castro, Dr. Castro, has created what she called a birth plan kit, where she helps the pregnant woman to anticipate and prepare, helps her ask the doctors and the nurses, what will it be like? What can I expect? And to ask for what she needs. And particularly, we work with a lot of immigrant women who come from cultures where the childbirth experience is very different than the hospital experience in the United States. And so requesting things that are culturally appropriate and that can be incorporated in the childbirth, including, for example, who will be present during the childbirth. Many immigrants want their mothers or their godmothers or another woman serving as a doula, as a source of support during the childbirth, and that can be accommodated in many medical settings. What she will need at the hospital for herself and the baby, who will bring her to the hospital, who will take care of the older children, who will be with her at the hospital, who will help at home after discharge. Work with pregnancy involves a lot of practicalities, and the sweet spot, I think, is helping to integrate the practicalities with an awareness of how do these practicalities reflect on emotional experience, so that we're constantly looking at both sides, practicalities and emotions. And after the perinatal, after the childbirth, asking what was it like? Because women often, particularly those who were abused, need to go through what happened to them, what their body felt, as a way of catharsis, if you wish, a way of releasing the anxiety of what the childbirth was like and the fact that they emerged, God willing, on the other side. What do they think of the baby? What does the baby look like? Do the mother and the father agree or disagree? We have all kinds of attributions to newborn babies, enlisting coping skills and external help. One mom who said, she starts crying exactly when I'm hungry too. I can't feed her when I'm eating myself. And the mother's mother said, I will hold her and feed her while you eat. It was like an angel coming and saying, we're repairing our relationship, daughter of mine. I know that I wasn't everything you wanted me to be as a mother, but now I'm an older woman, I'm more mature, I'm wiser, and I am here for you. I think often 3-generation interventions are extraordinarily healing at this time. And of course, helping parents, mothers, accept ambivalence, tolerate ambivalence. One woman said, every time I go by a church, I have the impulse of leaving her there. And then I imagine myself without her. And I think, no, I have to suppress that impulse and move on. Another woman said, I need to do my own thing. But then I really worry that if I'm doing my own thing, how is she managing? Is she lonely? So that struggle of individuation and relationship that is constantly there for women in particular. And here I want to just say that this approach of paying attention to practicalities and emotions really seems to work very well. These are findings of before treatment and after treatment, where the PTSD scores went down so much that there isn't even an overlap between PTSD before and PTSD after treatment when the baby was 6 months old. And the same thing for depression. No overlap in the scores. Depression scores have gone down so much. And the parental beliefs and attitudes, the pre-treatment were risk of maltreatment in terms of perceiving the baby as a source of trouble, and then much more positive scores after treatment. So what are the lessons learned and the message offered? That the perinatal period is a key opportunity to pursue social justice and mental health services hand in hand, to see clearly the injustices in the system, the tattered public health system that we have, and to speak up to correct inequities, and in the process to be emotionally available, physically available to the pregnant women and parents that are referred to us, to address the convergence of psychological challenges and social disadvantages, and collaboration between primary care and mental health in a way that is integrative and family-oriented. And I think that one very important last message is taking care of ourselves, because working in systems that are fragmented, that are traumatized, where it is very easy to feel hopeless and angry and enraged, burnout, vicarious trauma are real dangers. And I think that creating relationships at work, creating partnerships at work, finding sources of support in our work settings, but also protecting our private lives, engaging in conscious self-care. Those are really important, not only for ourselves, but also for the women and men and individuals and babies that we work with. Thank you very much.
Alicia, thank you so much for such a rich presentation. We have some questions. If people have their questions, please chat them into the chat box. I did want to acknowledge also that somebody did chat in a resource, the new Black birthing model, midwife, doula, doulo, and add lactation, and a new team approach. And I think as we're thinking about how do we really improve care, it's really important to think about new models that are out there. So let me just feed you some of the questions. One question was, how do we support parents who have a desire to form a bond, but are not engaging in these behaviors?
It's an excellent question, is the key question, because very often it's very interesting. Among the 100 women that we interviewed, who often spoke to us, we said to them, can you give us 2 hours? They often spend 4 hours with us. Unbelievable. They said, we never knew anybody was interested in my pregnancy. I never knew that I could really talk. But when we said to them, you've told me so much about the difficulties that you are encountering, would you like to have treatment? Would you like to come and have counseling? No, I don't need it. So there is very often this sense of, yeah, it was great talking with you. I unburdened myself. I never told anybody else what I told you, but I prefer not to. There's a lot of dropouts in treatment. So it's, I think, just one of those challenges, and really, I think, opening ourselves to what do they want. Very often starting with concrete services, with housing connections, with food, with diapers, with clothes, says, this is making me feel good. This proves to me that you are not just there to talk, that you are not just talking the talk, you are walking the walk, you see what I need. And that opens the conversation to how are you feeling? How's your body feeling? I think talking about the experience of the body is a great port of entry. And really being very judicious in not offering advice before we are kind of sure that the advice will be welcomed, and how to phrase the advice in a way that normalizes it. That is, yes, I remember that well. So many women tell me that. It's like, you mean I'm not crazy? So those are just some tidbits that we have found useful in the course of our work.
Sorry, you think by now we know how to unmute ourselves each time, but somebody had just asked the resource that I just shared, the new Black birthing model, midwife, doula, doulo. People were interested in more information on that. So if the person who chatted that in, if you have anything further where people could find a link or learn more about it, if you could send it to the panelists, and if somebody could just send that out to everybody, that would be great. We also got a question that I know we tried to address, and it's how do some of these concepts apply to same gender couples and to other alternative parenting models? And, you know, I just want to say that in this presentation, we recognize the fact that this was not inclusive, but that we also really wanted to say that present things that where we don't have any data or research at this point. Clearly, we need to do a lot of more work in terms of understanding some of the nuances, and so that we can better support alternate, you know, parenting styles or parent configurations.
Along those lines, I want to say among there was 101 interviewees in our study. One of them was a trans person, and we talked a lot with her, asking her to educate us about her experience. And she said to us, I'll tell you about my experience, but every individual is different. I cannot speak for my whole community. And so I think that that's why I was staying within my lane in terms of this is the experience that we have. But as you say, Evelyn, this is the question of inclusivity needs to be really taken seriously and studied in depth, and every person needs to be heard for his or her story. And then we can put the stories together and see what are the themes.
Absolutely. And we've got another comment. I very much appreciate your acknowledgement that pregnancy can also occur for transgender men, female to male, and or non-binary persons. I'm wondering if you know of any research currently occurring for this population that we might look into. And again, clearly a need to better understand what's unique and what's similar in these situations.
That's right. Yeah, and I'm sorry that I've been looking for it and I haven't found it. So if anybody in this group knows, I think they'll help all of us by sharing it.
Absolutely. And I think that we're hoping that today will also open up a dialogue where as things come out and whatever, we become a place to really kind of bring new information. Somebody asked, how do you support a caregiver who discloses fears, such as fear of possibly squishing a baby? And do you report that to child welfare? If so, how do you preserve the relationship, the ongoing dilemma that we always face?
That's a very good, such a good question, You know, for the last 40 years, I've been a consultant, a clinical consultant, almost on a weekly basis to Child Protective Services. And so one of the really sobering experiences of my life professionally has been to be in the Child Protective Services space and to be in the mental health space and to look at the commonalities and divergences, the contradictory experiences and so on. And I have to say that I am very, two things. One is, I think if we can, as clinicians, create partnerships with Child Protective Services, find resources within the agencies that we can go to, that we can consult with off the record, that we can ask about, then it becomes a system that becomes a partner rather than an enemy. And because Child Protective Service workers are very, very overwhelmed and scared that their names are going to appear in newspapers, that they are going to be responsible for the death of a baby, the death of somebody by not intervening. And therefore, there are often interventions that are much too drastic and not really necessary when it's a referral that comes at 5 o'clock on a Friday, for example. So I would not make a referral for somebody that says, I'm afraid of squishing a baby. I'm afraid that I'm going to do this to my baby, because she's talking out her fear. And the baby is in the belly, and there isn't any imminent risk. I just want to address this very concrete question. So that by the time that treatment ended, I was looking very carefully at how this mom was with this baby. And she could get mad at the baby. She never shook the baby. She never did anything damaging to the baby. And so I think that containing our anxiety and maintaining our clinical focus, and that's where we need a village. That's where we need to go to our partners and say, I can't sleep because I'm so worried about this. Do you think I should make a referral? Because often our talking about it can help us look at facets that we had not taken into account before. I think making a referral is a very, very serious step. And if we take it, I think to the extent that we can, we need to engage the parent. So we say, I am really worried. I'm very worried for your child. I'm worried for you. This will not be good for you either if you lose control, or that you lost control. And so I will sit with you and make a phone call together, if at all possible, to do it in a collaborative way. And I will be standing with you. And I won't leave you even after the referral. And over 40 years of doing this work, that really has been, it's worked in 85% of the cases in maintaining a relationship. How we do it is really, really important.
Yeah, and I think, how do we build a safety net and really build supportive responses and make sure at the same time that we're protecting the safety, both the mother and the baby? Always a challenge, and maintaining the relationship in the face of some of the needing to report oftentimes is really a challenge. So does somebody ask the question also about how do you support parents in dealing with grandparents who are reenacting their own kind of history of parenting with their grandchild?
that is such an exciting, now that I'm a grandmother, I tell you, I have a whole new compassion and understanding for grandparents and their role. And some of the most exciting work that we've done is when we realized that the grandparents' presence continue to have a toxic effect on the parent and on the baby. And we asked, could we meet the grandparents with the parents? And then we asked about the grandparents' experience. And the grandparents started talking about what happened to them. And the child, adult child, had never heard what happened to their parents, what their parents' childhood had been like, what, let's say, their immigration to the US had been like, why they came, what were the circumstances. And it was like, you never talked about that. No, I didn't think that it was relevant. This is my, etc. And so it becomes a way of creating intergenerational dialogue from one generation to another that opens a new compassion from the child generation to the parent generation, and the grandparents can start reflecting on how they are passing on what happened to them, to their children. So it's been a really exciting process, and particularly with adolescent parents, where the grandparent really wants to take over the baby, and the adolescent on one hand wants the grandparent to take over because they want to be an adolescent, but on the other hand resent the grandparents for robbing them of their motherhood or fatherhood. It can be very, very helpful.
Fantastic. Well, we're really running out of time here, but I just wanted to let people know that we're going to take a 15-minute break. And Alicia, thank you so much. That was so rich and so much information. And, we've come so far, and I think we have so much more to learn as we kind of think through how to improve care here. So we are going to take a 15-minute break, and then we're going to return, and we're going to have our panelists talk about some of the creative and wonderful innovations going on in New York City, New York State, and some of the levels of support that are being built in for parents and whatever. So please, you can either sign out and sign back in, or you can just turn off your mic and your phone and do whatever you need to do. But we will reconvene at 1:45 and look forward to a really rich panel discussion. So Alicia, thank you so much. We look forward to having you back for the panel discussion.
Thank you very much. Thank you.
Hi, folks. Just to let you know, we'll get started again in a moment for those who are still logged on. Hi, all. So I'm going to welcome everybody back and give everybody a few minutes just to kind of log back on. And I just want to say that just reflecting on this morning, first of all, I was just really thrilled about how we can all deepen our knowledge and understanding of how to really be more responsive in the perinatal period to all pregnant persons. But I also walked away just so humbled about how much more we have to learn, and particularly in terms of working with new populations and really understanding the unique needs. So anyway, I'm very excited to move into the afternoon, and we've chosen a series of panelists here to really talk about how do you take some of what we know and translate it into real direct practice. And in New York, we're very fortunate about some of the really innovative programming that's going on right now. And I think as you hear from our panelists, you also will be very impressed with some of the initiatives that are going on right now. So in the interest of time, I'm really not going to go through full introductions for all of our panelists because that would take the next 45 minutes. But we will put in the chat box their bios as well as their headshots and whatever. So if you want to learn more, you can really find out about it. But in order of presentation, we're going to hear from Dr. Uju Berry, who's a child psychiatrist and perinatal psychiatrist at New York City Health and Hospitals. She's the director of domestic and gender-based violence mental health initiatives, clinical associate professor at NYU Department of Child and Adolescent Psychiatry. We'll then hear from Dr. Zahira McNatt, who's the assistant commissioner for the Brooklyn Neighborhood Health. From Sonia Murdoch, who is the executive director, Postpartum Research Center of New York, and Dr. Elizabeth Warner, who is associate professor of behavioral medicine and obstetrics and gynecology and psychiatry at Columbia University Medical Center, associate director at Women's Mental Health at OBGYN, and the director of clinical intervention research in the Perinatal Pathways Laboratory. And the question that we've asked each of the panelists to address is, how can we improve the health and well-being of pregnant persons during the perinatal period? And just to say that each panelist may leave a few minutes for questions. Once again, chat them in. My colleagues, Dr. Susan Chinitz, clinical co-director, will help field the questions with me. And we're hoping to really have the opportunity to hear from some of you as well as your questions. So Dr. Berry, I'll turn it over to you.
Great. Thank you so much, Evelyn. And thank you to everyone here for allowing me to be a part of this wonderful presentation and to hear from one of my biggest people I'm so impressed by is Dr. Lieberman. As you can tell by her talk this morning, it was just outstanding. Her ability just to be able to weave through the multiple different nuances of what it means to take care of women during a perinatal period. So thank you so much, Dr. Lieberman. I'm also very honored to be here with my other panelists and can't wait to hear about about the work that they are doing. So I've been given some moments to talk about the work that I'm doing, and first of all, couch in the sense of how I think about my work. I think about my work as wearing multiple different hats. And so you'll hear that weave throughout my talk about how I think about those hats and how I use it to actually improve the lives of women and those who consider themselves women during the perinatal period. So the hats I wear are a clinician, an educator, a researcher, administrator, and a mother. I view all those works being simultaneous, and they encapsulate all those different roles because I do feel like they feed and fuel one another, and then one cannot exist without the other. For example, my one-on-one work as a clinician allows me to think about the questions, the hypothetical research questions, my research, which thereby influence what policies that we need to impart during my administrator hat that I have on. And then also influences some of the teaching I do to the next generation. So again, I'll speak about each of those a little further. But to give you a more broad view, so as Evelyn mentioned, I'm a child psychiatrist and reproductive psychiatrist by training. So I do see patients and do some clinical work. And then also I do some research. Currently at NYU, I'm the co-PI in a national NIH study called the Healthy Brain Child Development Study, which will be the largest cohort study of its kind, where we'll follow children prenatally. So in the womb, we'll recruit children while they're pregnant in the womb, and we'll follow them through age 10. And the reason we're doing that is because we're realizing that there is this understanding around the DOHAD model, or otherwise the developmental origins of health and disease. What this theory encapsulates is that it hypothesizes that environmental exposures during early life, so particularly in the in utero period, can permanently influence health and vulnerability to disease in later life. You heard Dr. Lieberman talk about this earlier, about that fetal stress dyad, that what happens when the fetus is in the womb can really impact how the children grow and develop later on. And so in part, we want to understand how the mom, how the childbearing person is doing to be able to really see those interactions. So this study will be, as I mentioned, will be the largest study of its kind. We'll be following around 8,000 children throughout the period. We'll be recruiting them now, starting this July, throughout the country. And because we're following 8,000 children, this will make sure that the study is sufficiently powered, meaning that will give us enough opportunity to really expose and understand those correlations that happen on that one-to-one level, but also on a much larger public health level. So therefore, we'll understand a little bit more about substance use. We'll understand more about poverty and social determinants of health. We'll understand a little bit more about intimate partner violence. We'll understand a little bit more about childhood trauma, historical trauma. But one of the other things I'm really excited about this research is that oftentimes people think about, what's wrong with you? And really, I think this is an opportunity for research to understand about what is going well for you. In other words, how can we understand about resilience? What are those supportive pathways? What are those access to care? What about green spaces or having less environmental toxins being exposed to you? How does that also impact and improve the lives of children moving forward, especially the parents who are childbearing? We'll do this by using EEG imaging, brain imaging, qualitative questionnaires, bioassessments, biospecimens, the whole gamut. And yes, I did say we'll be doing MRIs. So we'll be actually doing MRIs of the baby at 1 month old, which allow us to also get a better understanding of some of that biological markers that really kind of influence things. The reason why the study came about was actually because of the opioid epidemic. There is this large crisis that's happening within the United States and globally. And so about 25% of those 8,000 children will be actually from caregivers who have a substance use disorder. So that will be part of what we're building into that study. We're very hopeful that this study will actually, again, be able to influence policy, how we actually can take what we've learned from these different dynamics to think about, what are some of the negative qualities, but also some of the positive qualities that we can use to improve the lives of mothers and children. The other hat that I wear is as medical director and director of the New York City Health and Hospitals Domestic Violence Mental Health Initiatives. Health and Hospitals is the largest public hospital system in the country. And so this gives me the opportunity to really think about how do we embrace and support families who have an impact of IPV or DV or gender-based violence and sexual assault in their lives. Part of the work I do is really kind of going to a lot of different meetings and talk about policy changes, talking about some of the maternal mental health crises that are happening, but also talking about some of the interventions that we need that we've learned through research. I do this by overseeing 2 programs. One is the Family Justice Center Mental Health Program, and the second is a Domestic Violence Shelter Program, where we embed a multidisciplinary team of clinicians, adult psychiatrists, child psychiatrists, social workers, and psychologists. We embed them into one of the 5 family justice centers into the city or into one of the 57 domestic violence shelters in the city. So what are family justice centers? So family justice centers, and this also alludes to what Dr. Lieberman raised about when you're trying to do the work for these families, you really need to be integrative. You really need to think about a system collaborative response. And so our program works closely with the family justice centers, which are a one-stop shop for survivors of domestic violence and intimate partner violence and sexual assault. Basically, it's an opportunity for someone to come in if they're experiencing abuse to go and get help, and all the necessary advocacy services are there. It's always partnered next to a district attorney's office or to our family court office, which allows the families to go on site to file an order of protection, to get connected to a lawyer, an immigration lawyer if necessary, or a family court lawyer if necessary. There's also housing specialists, economic empowerment specialists, and then our program provides mental health therapy and psychiatric assessments as well. The Family Justice Centers is one of the gold standards by the Department of Justice for working with working with families impacted by violence. And then we also have the DV shelters, which I'll talk a little bit about. But one of the things about the Family Justice Centers, and the reason why this initiative came about, is that we really recognize that there's a need. And again, Dr. Lieberman did such a great job acknowledging this, that families who have a history of IPV are in higher risk for mental health disorders, including post-traumatic stress disorder, depression, anxiety, you name it. But it also leads to adverse consequences for the baby as well. And so there's really a need for us to really think about how do you work with families who have a history of trauma and kind of giving them the needs, the resources that they are necessary. But also recognizing that part of mental health and part of mental health well-being really falls along the range of how do you also provide concrete services. So how do you also provide housing stability? How do you also provide economic stability to these families who are better able to navigate some of the resources that the city may offer? Not surprisingly, many of the families who come into the Family Justice Centers are of low socioeconomic status with really high needs. Very similar to the demographics that Dr. Lieberman showed at the Zuckerberg Hospital. So many of them have high ACE scores. About 80% have ACEs above 4. So actually about 60% have them above 6. So those are high needs in terms of ACEs, in terms of social determinants of health. Many are still living in the community, but sometimes with the abusive partner. And many of them live underneath the poverty line. One of the benefits of coming to this program is that we are able to provide our services free of charge, which is very unusual, especially if you think about New York City, where there's really, it's really hard to kind of have access to free quality mental health care. And so we provide services free of charge to our clients. And also, it doesn't matter about your documentation status. And we also offer a lot of languages. And we try and meet the clients where they are at, where they're able to come in and talk about what their needs are. And we are able to provide that support. We did a case review of the first 106 patients who entered the Family Justice Center mental health program. And again, high needs with around 33% speaking another language other than English as their primary language, about 60% living below the poverty line. But what really struck me was that of these 106 patients, 40% had a history of a prior suicide attempt. And of that 40%, 60% had not seen anyone or told anyone in the past. So again, it speaks to this high need. So again, we already know there are high concrete needs, but also high mental health needs for these families, and they're just not getting the care that they need. They're barriers to access, for that matter. And so we really felt the need that this is an opportunity for us to really make a difference. And we've also noticed that during COVID-19, there's been an even increased need for mental health services for these families as well. When you think about the high risk of suicide attempt, how I like to couch is that, again, I'm a psychiatrist. When I think about really disorders that carry high morbidity and mortality, it's usually around 20% of those disorders where there's a history of suicide attempt. And here it's around 40%. So a much more riskier population that definitely needs the services we need. What's been wonderful is that even though there's a lot of concerns, we feel like we're able to make a difference in the lives of these families. So prior research has shown that within the first 3 months, in reality, that's really connected to being able to have that relational impact and that relational correlation with a therapist or a psychiatrist. Within the first 3 months, we're able to see improvements in depression. We're able to see improvements in anxiety. We're able to see improvements in trauma scores as well. And then this is also reflected by what the clients tell us, but also what the FJC staff tell us, that these families who connect with our mental health program are more likely to come to their case manager meetings, are more likely to go to their economic empowerment meetings, are more likely to find that job or find stable housing. So not only are we making a difference in the mental health disorder range, we're also making a difference in the functional ability, the functionality of these women who come into these programs. However, what we've also realized was that many of the caregivers who come into our program come in wanting to have mental health services for them, but also wanting to have mental health services for their children, or recognize the need that they need to do better in order to be the better parent. They recognize, as again, Dr. Lieberman did such a great job talking about this, that there have been some ghosts in the nursery about how they've been parented before, and they don't want to recreate that. And so there's an opportunity that we've noticed where we are able to get some of these self-selected people who can come in and say, I want to have mental health treatment because I want to help my kid, or I want to do better for my child. And in particularly, a lot of the people who say that are pregnant or postpartum or have children under the age of 6. So this is a particular niche area that we recognize as something that we want to do more with. In particular, when we think about stopping intergenerational transmission of trauma, here's an opportunity for us to really work with this population of early children, young age children who have parents who are willing to do the work. And so we applied and received a SAMHSA National Child Traumatic Stress Network grant. One of my colleagues, Dr. Erica Wilhelm, who's here, is the director of that grant. And that grant focuses on children under age 6 who have a parent who has an identified mental health disorder and who also has a history of IPV. So it's a 2-hit problem, if you think about it that way. We really focus on trying to work with that family and triage them to 2 sorts of different evidence-based treatments. One is child-parent psychotherapy, which is what Dr. Lieberman had talked about, and circle security parenting. One of the benefits of this grant is that it allows us to think about it from a system-level approach. So here's the administrator hat that comes on. From a system-level approach, how do we create these facilitated pathways into health and hospitals so that there are no waiting lists? There are no barriers to getting access, and that we're also training other staff on how to make sure that it works. We're also being trauma informed. So instead of telling parents you have to do X or do Y, we give them the choice. Oftentimes, many parents who have a history of trauma don't have that choice. Choice is taken away from them. There's no control that they have. And here, instead, we're trying to change that script and give them the choice to decide what works best for them. We're also going to be using the same model as we also received another large grant from the city of New York to expand the FJC model to work within the domestic violence shelters. There are currently around 57 of them scattered throughout the city. Most of them are in the South Bronx and in Brooklyn. And these domestic violence shelters are confidential locations. So although I said there are 57, I actually don't know where they are located. I have visited them, and often I don't get the address until the day before. And it's important that they're confidential because we want to make sure that they feel safe physically. And so the work that we want to do is make sure that the clients feel safe physically, but then we also want to make sure they feel safe mentally. And how we do that is it's very similar to the FJC model, where we do a lot of universal screening. So we screen the adults, but we also screen the children who are coming in then. And we do targeted interventions, referral to aftercare, and provide 24/7 coverage, because there could be some type of distress that happens at 3 o'clock on a Saturday, 3 o'clock in the morning on a Saturday. And we want to make sure that we're there for our clients as much as possible. What we've seen so far, and this just started, we actually launched into our 10th shelter this week, and we got the grant about less than a year ago. is that we're seeing that a lot of the families who come into the shelter system are either pregnant again or have a child under the age of 5. And more specifically, there's a lot of them who are postpartum. I would say when we had our housing situations with our clients where we talk about the program, in a room full of 20, about half of those are have a child, or probably a quarter to a half have a child under the age of 1. So again, there is that population that we're really trying to focus on and really trying to make sure that we provide excellent evidence-based interventions for them. Again, it's going to be offering free, culturally relevant, trauma-informed services, regardless of documentation status, regardless of what language we speak. We really just want to make sure we're focusing on a targeted approach to these families. So we're very excited about this as well. In addition, and so, I still have more to talk about, Ellen. So I just wanted to highlight. So those are kind of the what I do my work in, but the topics I do want to highlight have to do with training and meeting people where they're at. And so with training, I think training is so crucial. And being on this call and seeing around 300 people on this call really reflects that other people also think training is really important. I remember as being a medical student when we were shadowing OBs, just understanding what it was like to be in a delivery ward, and recognizing that there is joy to childbearing, but there also is stress to childbearing. I would not have known that had I not been trained to be able to see that. And then fast forward to my psychiatry residency and perinatal mental health fellowships, I really was able to better understand that internal struggle and those dualities, what Dr. Lieberman had referred and talked about. What are those questions? How do we think about an integrative approach? How does the past impact the present? All of those questions that learning help you become a better clinician. But training almost never seems to end. And what I want to impart is that with these two programs that I'm running, the FJC and the DV Shelter, is that we really understand the value for training for our clinicians too, for again, our psychiatrists, psychologists, and social workers. So we really embark on a really extensive training curriculum for them, especially because many of them are coming in with just understanding around adult mental health, and haven't been trained in perinatal mental health, and haven't been trained in early childhood mental health, and haven't been trained in family mental health. And so we do a lot of work in terms of supervision, didactics, to be better able to support our clinicians doing the work so they don't feel alone. And in particular, we want to be able to do this so that the statistics like that Dr. Lieberman showed, that like Black babies die when they're cared for by white physicians, no longer exists. We want to make sure that any of those inequities no longer exist. And the best way to do that is to talk about it, expose people to the realities, but also talk about how we can be better able to challenge that. The second thing I want to talk about too is highlight one of the other parts of our two programs is that the need to meet people where they're at and to recognize that each person is different. And view it from an individual lens, but also from a systemic lens too. One of the concepts I like to talk about with my clinicians is this idea of ports of entry, which is a CPP term. So the concept of ports of entry refers to a variety of elements in the parent-child relationship system that may be used as a starting point for an intervention. So the choice of which port is really determined by what's happening in the moment and how can you better engage with that family. And so you'll hear about, I remember one case I had where this mom came into the Family Justice Center. She was in her second trimester of pregnancy. She witnessed IPV between her father and her mother, had a history of depression, and had just left her partner after he had put his hands around her neck after he had choked her. One of the things I want to highlight about choking during IPV is that it carries a huge, huge mortality, where someone who's ever been strangled by an intimate partner is more likely to die by the intimate partner, and it carries a risk of 80 times the risk. So 80, not 8, but 80 times the risk. So huge mortality for around choking. But she came in after she was referred to me by the district attorney, because it's a felony in New York City to ever be strangled. And so she came to the district attorney and she was upset, of course, and was talking about feeling panic attacks and recently becoming withdrawn, and was not sure what she wanted to do with what it meant to be pregnant. And she was like, I'm not sure why I'm here. I'm here being seen me. And I talked to her, and one of the things I had with her was that you're here because you're hopeful. You're hopeful for change, that you want to do better for your child. And that was that port of entry that was able to work with that mom. And she was able to come see me on a weekly basis. I did therapy with her, med management, and she has her baby and is still on the road to recovery. But the other part I want to think about from a systemic level is really thinking about how do we work with families, and in particular the DV shelters. One of the things that came about when the grant was given to us was this idea of doing telehealth. And that was a great idea because after COVID, there was this change in terms of people more able to connect via telehealth. But when we talked to the clients themselves, they said it's not enough just to talk on the phone or on the screen with somebody. We want to actually have that physical presence with that person. We want to feel, yes, we feel physically safe, but we also want to feel mentally safe. And so clients themselves said, you know what, telehealth is not enough. I need you to come in person to the shelters, which was a huge ask because, again, these are confidential spaces. But we were able to work with the departments and the agencies to make it happen. So again, this port of entry, meeting the families where they're at, they want us to come on shelters, and so we're going to make it happen to make sure we're meeting their needs. And then also ensuring childcare, because again, a lot of these moms, they want to be able to talk about themselves, but also want to do it in a space that's set for them. So we're very hopeful about this too. And again, tying the research level, understanding more about resiliency from the HBCD study will also be another way, again, from a systemic level, understanding where are the ports of entry, what are the areas of resiliency that we can then make work, and understanding that some of this has to go back to training and better understand the needs for our families. And we're so excited to be doing this work in New York City. Again, happy to be here and happy to take any questions about the work we're doing.
Thanks so much. And in the interest of time, I think we'll move on. But one of the things I realized is, first of all, we really will want to get from all of you resources in terms of if people are interested in finding out more about your programs or how to access any services that might be accessible. So thank you so much. And we certainly want to hear about your research, and hopefully we'll all be learning together as we go forward. So thank you so much. And I'm going to turn over now to Dr. McNatt.
Hi, good afternoon. Thank you so much, Evelyn. Thank you to the panelists, Dr. Lieberman, for opening up such a great conversation for us today. Really appreciate the time and the opportunity to be able to connect on such an important issue. I thought I might respond to sort of the general question that was given to us in 4 ways. So one is I'd love to talk a little bit about the setting where our work is happening in the particular bureau that I'm in the Department of Health and Mental Hygiene. I'd love to talk a little bit about the question at hand: how do we care for and how do we ensure wellness of pregnant persons and their families? And then I'd love to describe just a few of the services that we provide to clients across the city, but also in particular neighborhoods that have been historically disinvested. And so I hope that that framing is a little bit helpful for the conversation. The first thing I'd like to share about setting is that, you know, we are all familiar with the city of New York and with the 5 boroughs. And I'd like to share that we have very specific focus on 3 catchment areas in the city. So one is where I work in North and Central Brooklyn, and that includes Bushwick, Brownsville, East New York, and Bedford-Stuyvesant. My peer colleagues work in East and Central Harlem, and then also in the South Bronx. And I highlight that because setting is so important. Place-based public health is so important, and understanding the health inequities we are talking about in the city of New York are very much based on zip code and where you reside. And so those 3 catchment areas I highlighted for you are places and spaces where we spend a lot of time focusing on maternal health and on maternal mental health. And it's important to highlight those neighborhoods because of their historical, purposeful disenfranchisement and disinvestment. As far back as redlining, resulting in many of the health outcomes that we see in the neighborhoods, food deserts, targeted investments in tobacco advertisement to young Black and brown people in those neighborhoods, extreme poverty, poor housing quality, high levels of stress as a result of environmental factors, and a number of other domains have allowed and forced us as a Department of Health and Mental Hygiene to say that we care about the entire city, but we're also looking at place-based public health approaches to inequity across the city, and then specifically for today's conversation to maternal health inequities. And so I wanted to highlight for a moment before moving into the topic at hand, why setting and place is so important in a highly segregated city, both segregated neighborhoods and segregated healthcare. I then wanted to move on to the heart of the question, which is what do we do for the care and the well-being of pregnant persons and their families, particularly in the settings that I'm talking about? And there are many, and I think we heard them all from all the presenters today. So thank you for narrowing down where I can focus today, because so much good information has been shared. And what I would highlight are three things that feel really important for supporting pregnant persons and their families in the city, and then specifically in historically disinvested neighborhoods, like where I'm focused in North and Central Brooklyn. The first, I think I heard from Dr. Berry, but really integrating physical health, mental health, and social services in one place and covering it through insurance. And we are seeing pieces of that happening across the city, but we have an opportunity to sort of rise to the occasion, do that work well, and create insurance coverage for physical health, mental health, as well as social services in one place and space. And part of the reason that's so important is because what we're recognizing is, particularly when folks are living in disinvested neighborhoods that don't have all the resources in one place and space, you are taking the bus in one direction to get a car seat, and then another direction to see your primary care provider or to see your OBGYN, and to another direction to find food access or a pantry or health bucks or SNAP enrollment. And so we are asking folks, asking residents who are the most disenfranchised in neighborhoods that have been disinvested to navigate our shattered, fragmented systems. And so the first thing I would say is we need integration, and we are seeing great examples of that across the city and have more work to do. The second is that we need an investment or greater investment in services that happen in the home and very close to home. And so I think we heard a little bit of this from previous speakers, and I'll highlight some of the programming that DOHMH has in this regard. So there is investment, but there's so much more to be done. And we're recognizing, even in this COVID recovery moment, that folks are looking for services that can be in their home or close to their home, in places and spaces and organizations that they trust and that are warm and welcoming. Which unfortunately many of our government and hospital type institutions are not or haven't been traditionally. And then the last thing I would mention I think is helpful in supporting the care and wellness of pregnant persons and their families is really going to the heart of the issue, particularly as we talk about the inequities in New York City. So we mentioned a piece of data in relationship to across the country between Black pregnant persons and white pregnant persons. In New York City, it's even worse. So in New York City, as a Black person, you are 9 times more likely to die as a result of your pregnancy than your white counterpart. And that's 3 times for the nation. And so we recognize in New York, we have an even tougher challenge of structural racism within our health systems, within our public health systems, and within all of the other social settings that are in support of pregnant persons. And so we're really looking at how do we eliminate structural racism in neighborhoods, place-based, and in the institutions that serve us. And it means we have to call out and name the institutions that need this kind of work that many of us on this call today work or are employed by. And so I just wanted to highlight those 3 areas as opportunities for us as we move forward this work on maternal health and maternal mental health, that we have the chance to integrate health and mental and social services in a way that is more convenient to folks. And that allows for all of it to happen in one place, be properly reimbursed by insurance, and make it easy for folks to get the social services and the mental health services and others. That we have the investment in home visiting, and that we are really tackling structural racism beyond, publishing documents that tell us that it's a good thing to be doing. In the last few minutes, I think what I would share are just the programming that's offered by the New York City Department of Health and Mental Hygiene. And that includes 3 programs I'll mention, but there are many more, and maybe I'll drop them in the chat if that's helpful. The first is the Citywide Doula Initiative, which was launched last year, CDI, which many folks have heard about. But the ultimate goal is to get women in the tree neighborhoods, some of the most disinvested neighborhoods across the city, access to free doula care during your pregnancy, at your labor and your birth, and 2 months into the postpartum period. So if you want to learn more, happy to share during the Q&A. The second are family wellness suites, which are not a home visiting model. They exist in the 3 neighborhoods I mentioned: South Bronx, East and Central Harlem, and then North and Central Brooklyn. They're physical, beautiful, family-friendly, warm spaces for classes, workshops, lactation, counseling, referral to mental health services, recognition of perinatal mood and anxiety disorders in clients. And so we're really excited to be able to have these kinds of spaces and hope someday there'll be more of them. And they are centered in social connection in neighborhoods where social connection may have been challenged by a variety of structural determinants of health. And then the last one I'll mention is the Nurse Family Partnerships, or NFP, which I think many folks are familiar with, that sits within DOHMH as well. And it is a nurse visiting program that allows for clinical as well as non-clinical support, recognition of maternal mental health concerns, proper referral into those services from the safety of your home and that space. What I'll share in closing, I think, is that we have an opportunity in the city of New York to center the most marginalized persons, and that will uplift the care for that population, which in New York is Black and Latino, and it will uplift the care for all women who are considering giving birth in the city. And there's so much work to be done on working through anti-racist frameworks, on being place-based in the efforts that we're taking on within public health and medicine and nursing and midwifery and doula care and social work and all of the amazing fields that many of you are coming from. And so we have done great work as a city, and we also have much to do to eliminate these maternal health inequities and maternal injustices across the 5 boroughs. And so I'll drop a few things in the chat, but otherwise it's been a real pleasure. Thank you so much.
Thank you so much. And I do want to let participants know that we will reach out to all the panelists, ask them for a list of resources. If there are questions that we don't get to today, we'll make sure that we send them out afterwards. And what I'm realizing is today's conference is really just a beginning dialogue. It is not kind of a one and off. So clearly it's raising a lot of important initiatives, and there's a lot of exciting things going on. So thank you, Dr. McNaught. So now I'm going to turn over to Sonia.
Thanks so much, Evelyn. I'm Sonia Murdoch, the Executive Director and co-founder of the Postpartum Resource Center of New York. And I'm also someone who supported her sister through postpartum psychosis. So thank you to the conference organizers for inviting me here today. Thank you to Dr. Lieberman for her important work and her presentation, and also to the panelists to learn from their work also. So when asked, we can improve the care and well-being of at-risk, as well as I would highlight the highest risk parents in the perinatal period with making community support, particularly with the inclusion of parental mental health peer support for new families, a priority in our society. As Dr. Lieberman highlighted today, and I will go over these because I think it's so important, because I loved how she really connected the dots for all of us. So with especially the interconnected issues of maternal mortality, preventable maternal deaths, racial health inequities, the issue of child abuse, racial health inequities, reproductive justice, poverty, social determinants of health, addressing basic needs, intergenerational trauma, domestic, intimate partner violence, substance use, mental health. The mental health crisis we're experiencing right now, post-pandemic, is a major public health crisis. Being with you here today, I was reminded of further how I got here and with the importance of improving care and well-being for all high-risk parents. I remember being back rocking and snuggling with my niece when she was a baby, singing with her, talking with her, feeding with her, and always making sure I was wearing my sister's shirt. I was wearing my sister's shirt because we were in the midst of a crisis. My sister and brother-in-law, our families were in a crisis after my sister unexperiencedly experienced postpartum psychosis, and she was psychiatrically hospitalized. I took care of my niece in this way, always wearing a shirt of my sister's because the hospital did not have a policy on visitation. And I wanted to make sure this new baby, who is the center of our world now, knew that she was well loved and cared for by her mommy. And actually, I also did read at the time Dr. Brazelton's book, Touch Points, which was very helpful. After supporting my sister, brother-in-law, my family through postpartum psychosis and severe postpartum depression, I began to think, what happens to other families that are not like mine? Maybe they don't have different advantages. What if somebody doesn't have a sister? So I co-founded and created a solution, the Postpartum Resource Center of New York, and our programs and services, including parental mental health peer support program. With providing support, understanding, and education to others, including addressing social determinants of health for pregnant women and new mothers and families with young children from those with lived experience, can prevent detrimental effects of these highlighted issues today. We can also further help to save lives of mothers and children and build healthy families. Dr. Ruta Nonax has stated social support is the cornerstone to recovery from perinatal mood and anxiety disorders. To improve care for those at risk, parents, we have available access to social support with 3 points, which I've created, I call it SUE, supportive, understanding, and educated. Many times PMADs, perinatal mood and anxiety disorders, are called the no casserole illness. When a new baby arrives, we hope that everyone is looking to help that new mom, mother the mother, from the work of Sally Blackston, and nurture that new family so they might show up with a casserole, as well as maybe other help. With parental mental health and the stigma, the shame, not knowing how to reach out, how to react when a family is going through a perinatal mood and anxiety disorders, many times it's called, again, the no casserole will be arriving, the no casserole illness. So one way of 3 ways to improve care is being supportive and learning and participating in what we have created, we call the Ask the Question campaign. It's simply to ask a parent to be a new parent, how are you doing? How are you feeling? We encourage people, look that parent in the eye. How are you doing today? Then be prepared to listen and hear their answer. With whatever concerns that they have expressed, to direct them to the help and resources they need. One such resource is the statewide social support network of the Postpartum Resource Center of New York. And I know there may be people joining from outside of New York State. So maybe you have something like this in your state, in your community, or through nonprofit organizations such as Postpartum Support International. Our mission here in New York is to increase awareness and access to care for New York State birthing persons, moms, dads, and their families at risk or experiencing a PMAD, and to fulfill our mission by increasing education, prevention, screening and treatment, and support services for PMADs. We provide support programs and services, training, healthcare providers and consumers, and building community partnerships. The Postpartum Resource Center of New York's principal activities are providing a statewide toll-free helpline and online support 7 days a week. We went 7 days a week from the result of the pandemic. We are available 9 a.m. to 5 p.m. for free confidential emotional support, information, resources, and care coordination, with additional free support with our parental mental health peer support program and a team with lived experience of PMATs. We have a free online statewide PMAT resource directory. We also distribute awareness educational materials to consumers, community providers such as maternity hospitals, medical professionals, home visitors, doulas, WIC, child development centers, programs, domestic violence programs, whoever is interested in becoming part of that safety net for parents and new families. We host several free Take Care of You virtual support groups. We have our Community of Caring program where we provide basic needs, such as diapers that have been mentioned, baby supplies, maternity care supplies. And especially for those who don't know the importance of connecting new families to diapers, because research shows diaper insecurity can be just as stressful as food insecurity. We also have a training institute where we provide training for doulas, as well as grant rounds, presentations, and replication of our Circle of Caring support group program. We host a free webinar series called Moving on Maternal Depression, and we invite others to get involved and learn and make a difference in their communities. So that's first with supportive. The second way that we have found to improve care is by being understanding and bringing that top of mind. To be understanding, to be empathetic to what the person is experiencing in the perinatal period. As with Dr. Lieberman sharing her and her colleagues' work with evolving a coherent identity as a mother. That triangle, so important, the importance to be there for that person evolving, to hold space for them in an active way, an empathetic listener who is connecting them with racially and culturally appropriate supports just for them. Many parents are reporting to us that they feel unheard, they are being dismissed, and that many times people are not getting back to them. Also, that no one understands them culturally. To understand with connecting the dots of all of these issues discussed today, including parental mental health, and to help the most risk parents, also as Dr. Lieberman shared, is the whole family approach, and including the parent, possibly the mother, father, child, but also looking further if it is going to be a single parent home, what other supports are available. Also, as Dr. Lieberman shared today, I think that a key highlight in her presentation was also understanding that each pregnancy is different because of the circumstances. The current social support system available and basic needs being met also need to be considered, and also how to be of help. It's very important that understanding piece, the empathetic listener, whoever is going to hold space for these parents, because I truly believe from our experience, if we don't listen to what that parent needs to say, this may end up in their suicide letter to us for them to be heard in our society. And lastly, the third way we have found from our 25 years of experience of supporting families with parental mental health is with the education. How can we improve the care of well-being of at-risk parents in the perinatal period is with the education. Dr. Diana Barnes from the Center for Postpartum Health has stated, prevention of tragedies is in education. As Dr. Lieberman and other panelists have shared today, there's a critical need to address all of the issues presented today to prevent and decrease the adverse effects on infants, children, their parents, and our society as a whole. As we all agree here, I'm sure so much is at stake. And unfortunately, New York has had very, very sad tragedies. And as we've learned also many times, sometimes those tragedies could have been prevented. With the adverse effects of untreated parental mental illness, the importance of supporting babies and children for their mental wellness, social, emotional development, and for school readiness. We have learned from parents themselves that programs may exist, but they are not getting to that help they need due to ignorance, denial, not being screened for their mental health, shame of mental illness and their situation, fear of their baby being taken away, major distrust in certain high-risk groups, the stress, the weathering, the trauma from C-sections, having a baby in the NICU. So the way we have found to go from nobody told me to somebody told me and helping to get to that piece of closing that gap to increase families getting to the help they need for perinatal mood and anxiety disorders, that we are providing our parental mental health peer support program with funding, thankfully, through the Mother Cabrini Health Foundation. It's an innovative way to further get to those who are most vulnerable, high-risk families in the perinatal period, and further helping to begin them starting to create a village. We are looking to set them up for success, where many times they feel left behind and they're feeling that they're being set up for failure. By providing access to education and support from the resource coordinators, bilingual resource coordinator, peer coaches who all have lived experience with PMADS and have received extensive training, parents are expressing that they're not feeling alone, they're becoming educated, empowered, understanding their mental health symptoms and learning how to put it all together with their own Take Care of You action plan. They are being put at ease and feel hopeful, not feeling alone, and that they are not losing their minds and they won't be judged and they don't feel ashamed. Most of all, they're feeling safe in a non-judgmental free zone. And others who've been there and now they're going through, no one will be understanding me, to what do I do to get help for me and my baby? So as I wrap up here, I'd like to share a quick story that with being supportive, understanding, educated, when I was in South Africa and had the opportunity to speak at the first conference on perinatal mental health there, I met women from the Zulu tribe. Speaking to the women from the Zulu tribe, I was very curious to know, how did they treat mothers' mental health in their society? And at the time, I didn't realize certain cultures didn't even have a word for depression. So I asked, what kind of support do new families get when they have a baby in your culture? They came back to me and they said, we see every baby as a blessing. And whatever they need for 6 months, we will come together, whatever they need, and we will help that family. So they actually asked me through an interpreter, what kind of help and support do mothers, fathers, families get in the United States? And I wanted to represent our country well. So I said, well, maybe 2 weeks of help. I was thinking sometimes, especially with the first baby, and if a woman does have her own mother, maybe she gets a week of help from her mother, maybe a mother-in-law comes in, and if she has access to doulas, other support, but maybe just 2 weeks. So what happened next? There was a lot of talk back and forth. I was getting concerned and nervous, and I asked, is everything okay? And they said, we want to make sure you said 2 weeks and not 2 months. And I said, no, 2 weeks, 14 days. So what happened next is they asked, please bring a message back to all mothers, fathers, and families in the United States. These women lined up in front of me. They put their heads down, made very sad faces, and they drew tears down their cheeks very slowly. So as they did this, I began to think, I don't know what their community looks like, but I know that I think they understood the question I was asking. And it's what we all care about here today, is that giving that baby the strongest start ever and supporting that family. So as Dr. Lieberman beautifully, I want to say, emphasized here today, the multi-generationalist of these illnesses, these traumas. So with this, I encourage everyone to please include and look to further include social support in the perinatal period, because that may be the missing piece of why that these families are not getting connected to these wonderful programs and may not be continuing with the programs because they need to be connected with the help of those who have lived experience. So as I leave you with this, I hope another resource, an important step here will be my mentor, Jane Honickman. She just wrote a book, and Jane with the Postpartum Action Institute, and it's called Postpartum is Forever. And I think it's appropriate here because its social support is important from conception through grandparenthood. So thank you again for having me.
Thank you so much, Sonia. And again, we will be reaching out to all the panelists to get all the resources that were shared today and send them out to everyone. So it's really, I'm excited because this really feels like it is connecting a lot of the dots. So now I'm going to turn over to Dr. Warner. Thank you.
Hi, so I will be brief. I know we're a little bit short on time. I'm so happy to be here today, and it was so wonderful to hear from Dr. Lieberman about all of her important work. Thank you so much for including me in the panel. I'm a perinatal clinical psychologist and on the faculty at Columbia University Medical Center, and I'm in both the departments of OBGYN and psychiatry. And as mentioned a little bit earlier, I'm the associate director of our women's mental health program in the Department of OBGYN, which is a clinical mental health service in our department that's aimed at providing embedded mental health care within OBGYN. And we began this service in 2019, and it's been so amazing to have the opportunity to work hand in hand with OB providers to both screen their patients and provide them like an immediate link with mental health care. My passion is really about increasing accessibility for mental health care during the perinatal period. And I think a little bit of what I'll talk about calls back to when Dr. Lieberman was talking about patients being offered treatment and saying, oh, no, that's not for me. I want to figure out ways to help mental health care feel like it's something that people not only could use, but feels like something that they'd be interested in pursuing. So my specific clinical interest is in the prevention of postpartum depression. And I'd love to talk a little bit about the clinical intervention that my colleague Catherine Monk and I developed. The intervention is called PrEP, P-R-E-P-P, and it's an acronym that stands for Practical Resources for Effective Postpartum Parenting. And it's aimed at preventing postpartum depression for people who are at risk. So specifically, it's an intervention that is aimed at leveraging the unique bidirectional relationship between parent and baby. And this is really important when we think about postpartum depression, because studies have consistently shown a link between infant temperament, difficult fuss, cry, and sleep behavior, and depression symptoms postpartum. We start our treatment actually during pregnancy. So women are identified as at risk during pregnancy, and we meet them twice during the third trimester. Then we check in with them after birth. We check in with them again 2 weeks after birth. And then we have a final session with them at 6 weeks postpartum. And we work with people to use their own childhood experiences, both the good and the bad, to set expectations and set intentions for their own parenting. We help them to develop coping mechanisms. We teach them mindfulness meditation skills to manage stress, as well as to help themselves get back to sleep, both during pregnancy and postpartum. As we know, sleep is really essential to mental health. We also provide them with psychoeducation, so we can set some realistic expectations of what life will be like postpartum. And we also teach people useful behavioral skills to help babies to sleep more and cry less, and so that parents can feel more efficacious. All of these skills and the psychoeducation are provided in a way that really takes into account who this person is. We want to think about their life circumstances as well as their culture when we're providing these skills with them and making sure it really feels like something that's egosyntonic to them. We've designed this intervention with a specific aim to make it more accessible than some other psychotherapies can be. So first, we designed it to be brief, so it's low cost and efficient. There's only 4 sessions and they're billable to insurance. We also have been able to train over the past several years now many different kinds of providers. So I've trained psychiatrists, psychologists, pediatricians, OBGYNs, social workers, community mental health workers, OB nurses, midwives, and occupational therapists. And we also feel like it's more accessible. Some women are reticent to take medications at this time for depression or anxiety. And so having a psychotherapy treatment can help people to feel more likely to engage in it. In addition, we really try to bill it as you're going to be in a program, and we're going to help you manage stress and help your baby to sleep more and cry less. We call the therapists providing the treatment coaches, which I think is another way to sort of destigmatize this particular psychotherapy. And we also offer this when we do it in person in conjunction with routine medical appointments. So you come in for your ultrasound, and then right after your ultrasound, you see your PrEP coach. We've also been able to adapt it fully to do it via telehealth, which was, of course, very necessary during the pandemic. So we're able to offer it both ways. We've been able to train clinicians both as part of our Columbia, New York Presbyterian ambulatory care clinics, and we also offer it as part of our regular OB/GYN service. So any patient who is getting perinatal care is able to receive this service and use insurance to pay for it. And we've, in the past 2 years, we've launched a PrEP training center, and we've trained dozens of therapists all over New York City. We've also trained people all over the US and now the world. And so it's been a really exciting way, I think, to provide a treatment, which maybe is not enough for everyone. So someone with very severe trauma or very, very serious mental illness, people with active mania, psychosis, this may not be the best treatment for them, but it may be something additive to a more comprehensive treatment. And for many people, it provides the difference between becoming quite depressed postpartum and really being able to manage the stresses of the postpartum period and feel more confident and be less likely to develop depression and anxiety symptoms. So that's about it for me. I tried to kind of go quickly so we had time for follow-up questions at the end. I hope that's okay.
Thank you so much. And I also want to let people know that Dr. Warner will be doing a webinar for us coming up in June on her preventing postpartum depression. So I'm so excited about the kind of richness of all of the resources that were being shared here. And we will compile them. We will send them out to everyone. And hopefully this is the beginning dialogue. I thought, today was going to be a great conference, and, we'd all walk away feeling very edified. And I feel like we're walking away saying, like, we need more, we need to collaborate more, we need to connect the dots. So thank you all. So I don't know if there are any questions, but also whether, Alicia, whether you have any comments you'd like to make in terms of closing this out here. You're on mute.
I just want to say, Evelyn, I was thinking of you with such admiration and gratitude for bringing this extraordinary panel of powerful, fantastic women together. And I was thinking, I was having this image of creating a Golden Gate Bridge between San Francisco and New York, where I could go back and forth and hang out with all of you and learn from what this panel has done. I was thinking that as a group, you have covered it all. And I was thinking of how each one of the panelists has moved so gracefully from the intimate sphere. What Ms. Murdoch, Dr. Murdoch, said about the shirt of her sister, and that moment of connection with the baby, making sure that she wasn't replacing her sister, but was complementing her sister. And then the generosity of her thinking, not everybody has a sister. How can we make sure that everybody has a sister-like resource? And creating a peer a program where services are provided without stigma. And then Dr. Berry talking about ports of entry, again, as a really intimate way of saying, where are you now? And then listening to what they're saying and moving from there to a systems approach where physical health and mental health and concrete resources are provided in the same space so that it is really holistic without losing attention to detail, because God is in the details. And then Dr. McNatt, I just want to say, when you said home services, and when you said free doula services, my heart just went up in a little song of gratitude for your speaking to that. And then Dr. Werner, when you talked about sleep more and cry less, I would imagine mothers would just want to embrace you when they hear that message, because when we are so exhausted postpartum and when we are so overwhelmed, this idea that there can be such a concrete, kind way of saying, I am here to help. And so just the four panelists together, it's just been an extraordinary tapestry. And I am so grateful for having witnessed and listened to this. Thank you so much. And thank you, Evelyn, for this
thank you.
extraordinary day.
Thank you. And as I keep saying, I mean, I think this is a beginning dialogue. I feel like there's so much going on, so much we're going to learn together, and we hope to stay all connected here. And so please stay tuned, sign up for our listserv. We're going to post in the chat box our evaluation for today's presentation. Thank you for all of you who stayed with us, but I do hope that it really brought everybody additional resources, additional information, and that going forward, we can really kind of try and work together to really create the safety net. And I would love 6 months of whatever that baby needs, we're there for them. And you know, there's a very poignant story, Sonia, and I think that, you know, in some ways too, what we do is just not enough, and we need to keep thinking about how to do it better. So thank you to everybody. We are going to put into the chat box the evaluation form, and really encourage everybody to please fill it out. Let us know your thoughts, let us know your ideas. If there are ideas of areas you'd like to get more information about, please let us know. And again, we will be compiling all the resources that were given out today so that you'll have them all in one place. And if there were any unanswered questions, we'll also try and respond to them. So many, many thanks to all. Alicia, that was wonderful. Thank you to the panelists.
So much.
And I really feel like I'm walking away, you know, having learned so much and really interested in knowing so much more. So thanks to everyone.
Thank you. And thank you for the audience for their questions and their comments and their resources. Thank you so much, every one of you.